I'm Geoff Sonn from Stanford, and I'm going to talk about the urologist perspective in selecting patients for focal therapy. I'll avoid a general introduction to focal therapy as I know that this has been covered already today. Here's a sample case. This is a PSMA PET MRI, which I don't get in all of my patients, unfortunately, but does create really nice images to show as examples. This is the ideal patient in many ways with a single tumor on one side of the prostate. We treated this man with focal HIFU, and you can see complete resolution of the PSMA uptake, and that portion of the prostate is gone. This is really the ideal scenario, but in real life, often things are messier, and we have to deal with situations that are not the ideal. So today I'm going to talk about two main topics. One is what I would consider to be optimal patients for focal therapy. And the second, try to explain and come to an understanding about the causes of failure for focal therapy so we can try to reduce those failures. Let's start with optimal patients. Now, the first thing I ask myself when I see somebody interested in focal therapy is, will this man potentially benefit from treatment? And what does that mean? Well, first of all, is he healthy enough to derive some benefit? If I see somebody that's particularly old or has a lot of severe comorbid medical conditions, I'll talk to him about active surveillance as an alternative to focal therapy. But in an appropriately healthy patient, especially one with this Gleason 7 intermediate risk prostate cancer, really in many ways, that's the ideal scenario. For lower grade tumors, I recommend active surveillance to virtually all patients. And for higher grade Gleason 8, 9, 10 cancers, I'm generally less bullish about focal therapy, in part due to the risk of occult metastatic disease, and the stakes of failure are higher. Why do we look at Gleason 7 cancer as the ideal scenario? This was a nice paper from a group in London that shows increasing failure rates with higher grade tumors. So we really like to stay in this sweet spot of Gleason 7 prostate cancer. Secondly, we want to know where that cancer is located. It should be clearly visible on imaging, and that imaging is usually MRI. Perhaps increasingly, we'll see more and more PSMA PET imaging, but for the time being, MRI is the mainstay in imaging. And not only do we want to see an area on MRI, we want that to be concordant with the biopsy result. We want to avoid situations where the biopsy shows a cancer in one area and the imaging shows the cancer in a different area within the prostate. Now, the ideal scenario is a case like this with a unifocal tumor and nothing anywhere else in the prostate. In practice, also, I'll accept men with small amounts of low-grade cancer elsewhere in the prostate, ideally that's not MR visible, and those are still good candidates for focal therapy. Also, we prefer when it's a unilateral cancer, ideally out to the side of the prostate, although we are able to extend treatments beyond the midline, so a tumor that approaches or even just crosses the midline is not out of the question. Here's an example of a patient that I treated recently with salvage HIFU for recurrence after proton beam radiation. We can see here on T2 a cancer on the left side of the prostate that extends a bit beyond the midline, also seen on PSMA PET. This is a patient, again, I treated with HIFU. And we can see here the immediate post-treatment, post-contrast MRI. We see this nice non-perfused volume here, showing that we can extend the treatment beyond the midline as needed to get an appropriate margin. Now, what else? Well, it's important that we match the energy source to the location of the tumor. No single method of focal therapy is going to be ideal for tumors in all locations. For example, posterior lesions in my hands are usually handled with HIFU, while anterior lesions may be managed with cryo or transurethral ultrasound ablation. Just as an example here of a patient that we treated recently, we can see on multiparametric MRI in a right anterior cancer. This is not a good case for transrectal HIFU, but is a great candidate for TULSA, which is what we did in this case, treated the right anterior prostate with transurethral ultrasound, and we can see no more prostate tissue present and no more diffusion defect. So important to match the appropriate ablative energy to tumor location. And finally, it's really important to make sure that our goals are aligned between patient and physician. Most men who are interested in focal therapy are those that are going to highly prioritize functional preservation, but it's important that they recognize that they are subjecting themselves to a higher chance of needing a secondary or salvage treatment for recurrence. And that makes sense. If we're treating a portion of the prostate, it's more likely that they may recur in the untreated area. And I also make sure that patients understand the risks of focal therapy. Even though the risk may be fairly low, there are certainly men with new onset erectile dysfunction. Decrease in the ejaculate volume is quite common. So it's important that patients understand. And that's, I view that as very important also in selecting appropriate patients. It has to be men that really have these goals. So let's move on to the second goal, which is talking about causes of failure. And I like to think of these in two groups, either the in-field failures or the out-of-field failures. And what do I mean by that? In-field meaning tumors that are in the area that we know about, either right in the heart of it or out in the periphery in the margin. So, sample case to explain this in-field failure issue. This is a patient that we saw that has a lesion in the right prostate, seen on T2 and diffusion. He actually ended up deciding on prostatectomy rather than undergoing focal therapy. And what we see on his final prostatectomy pathology is the tumor was in the right spot, but we see an extension of that tumor 14 millimeters beyond the MRI visible lesion. So this is somebody, if we did a 5 or even 10 millimeter margin, we're likely to leave residual cancer behind. And this would be what I would view as an in-field failure due to lack of expansion of the margin sufficiently at the time of treatment. How about out-of-field failure? What does that mean? Well, here's a case. We can see a nicely delineated lesion in the right peripheral zone. This patient also ended up opting for prostatectomy rather than focal therapy. And what we saw from his final prostatectomy pathology is that the known tumor lined up very, very well, but he actually had a secondary tumor on the contralateral side that had not been called on his initial MRI, nor had it been biopsied. And as a result, if we had done focal therapy, this patient would have failed with an out-of-field failure. So what's the best way to try to reduce these in or out-of-field failures? I think it's to really do a thorough biopsy, to ideally include not only just targeted sampling, but also some systematic sampling to help us look for additional cancer foci, as well as to figure out what the appropriate margins are of the tumor that we do know about. And the second thing I think about is short versus long-term failure. Short-term failure, meaning those guys who want a biopsy, let's say 6, 12, 18 months after focal therapy, we find residual cancer. Often that cancer is going to be out in the periphery of the area that we did treat, perhaps because of not extending the margins enough. Or the long-term failures, which are those that are going to be occurring several years down the line. So what are the key takeaway points I'd like to get from this talk? One, as a urologist, I think it's very important that we carefully reread the MRIs before biopsy and certainly before focal therapy, with the idea of looking for additional lesions that perhaps weren't originally called when the MRI was done, and therefore may not have been targeted at biopsy. And so we won't necessarily know if there's cancer elsewhere. So important when looking at MRIs for planning focal therapy to think about these issues of multifocality. So might there be additional tumors that weren't originally seen? And as well as paying very close attention to where this cancer is located so we can appropriately match the ablative energy based on the location of the tumor. Also, to try to liberally use repeat biopsy if necessary. If there's some uncertainty about the extent of the tumor and the candidacy for focal therapy, repeating biopsy can also be helpful in helping to decide what are the chances of focal therapy being successful. And then finally, I think that PSMA PET MRI showed you a couple of sample images that create really beautiful images. I think this is emerging. We'll probably see more of this in the future, but for now, the role remains uncertain and availability is not widespread. Thank you.